Patrick is a 78-year-old male who has worsening of his left-sided heart failure and COPD. He is very tired and coughs regularly, and he suffers from dyspnea. His legs are swollen from the knees down, and he walks slowly. His current observations and body size measurements are blood pressure 135/85, heart rate 155, weight 95, height 180, and waist circumference of 104. His previous relevant medical history is smoking from age 20 to approximately 60. He quit smoking in his early 60s. Myocardial infarction to a branch of his left coronary artery, age 68, and Patrick's fasting blood test results will be included later in the presentation. Patrick's regular cough and dyspnea are due to his chronic obstructive pulmonary disease. COPD is an umbrella term, and it is likely that Patrick is suffering from both chronic bronchitis and emphysema, as clinical features of each disease match his clinical manifestations. Patrick has a weight of 95 kilograms and a height of 180 centimeters, calculating his BMI at 29.3, putting him in the obese category. When we then account for his waistline of 104 centimeters, this shows that he has a particularly large amount of adipose tissue around his abdominal organs, known as central obesity. The extra weight bearing down on his body, especially his thoracic cavity, puts additional pressure on the lungs. This makes the diaphragm and accessory muscles work much harder for conduction and respiration to occur. Also, looking at the backwards effects of left-sided heart failure, the congestion of blood leads to pulmonary hypertension and the leakage of blood into the lungs, which limits gas exchange and creates further shortness of breath. Patrick's heart rate is 155 beats per minute, and considering that the normal range is 60 to 100 beats per minute, then this is considered very high. There are many contributing factors, however, his elevated heart rate is primarily due to Patrick's COPD and worsening left-sided heart failure. The injured heart muscle pumps out low amounts of oxygenated blood, which is detected by the peripheral and central chemoreceptors. Signals are then sent to increase the heart rate via the sympathetic nervous system. These receptors also detect poor gas exchange in the lungs, and signals are sent to increase the rate and depth of respiration. As there is continuous flow of poorly oxygenated blood from the lungs to the heart and vice versa, this cycle continues to keep the heart rate high. There is also impaired blood flow to external organs because the priority is the heart, lungs, and brain. The renal artery, therefore, is heavily restricted, which results in the activation of the renin-angiotensin-aldosterone system, even though blood volume is sufficient elsewhere at the priority organs. Because of this, sodium and water are retained within the body, which increases blood volume and blood pressure, making the heart work harder and beat much faster to compensate. Patrick is 78 years of age and previously smoked for over 40 years. Emphysema is caused by progressive, irreversible damage with the constant irritation to the alveoli from cigarette smoke, causing increased mucus production, and over time the alveoli become overburdened, collapse, and lose their elasticity. This is evident by Patrick's constant cough as the lungs are trying to bring up the excess mucus secretions. Smoking has also damaged his cilia. The mucociliary escalator is one of the major defense mechanisms which protect the lungs. This leaves Patrick with little defense against bacteria entering his airway, which causes inflammation and narrowing of the bronchial tubes, otherwise known as chronic bronchitis. This worsens gas exchange even more by the hypersecretion of mucus-producing goblet cells trying to contain the bacteria. However, because of impaired airway clearance mechanisms, the airways become even more restricted, which decreases oxygenation of the body's tissues, known as hypoxia. This is evident in Patrick with his dyspnea and general tiredness. The number one risk factor for heart failure is having experienced a myocardial infarction. Thus, Patrick's previous history of an MI to his left coronary artery at the age of 68 is the most probable cause of his left-sided heart failure. After a serious ischemic event, the heart is left with a permanent impaired ability to contract, and the cardiac penumbra consequently has to attempt to compensate and work harder. This will lead to hypertrophy, which is the thickening and enlargement of the heart tissue wall. The infarction area is filled with collagen, and a fibrous mesh forms in order to create structure and support. However, this scar tissue is very stiff and only restricts the heart's natural contractions more, which contributes to heart failure. We can also look at other contributing factors for heart failure, such as hypertension and hyperlipidemia, both of which can contribute to myocardial infarction or heart failure. Hypertension is significantly high blood pressure, which puts abnormal strain on the heart and blood vessels. If Patrick has high levels of cholesterol in the blood, then plaque will have built up on the artery walls, further narrowing the vessels. The overall result is restricted blood flow to the myocardium, and a myocardial infarction occurs, which leads to heart failure because of the permanent damage caused. The relationship between COPD and heart failure is not fully understood. However, both disease states exacerbate the other, which leads to both conditions worsening over time. For example, heart failure leads to a decreased stroke volume, creating low oxygen levels, and has a backward effect, leading to congestion in the lungs. This leads to pulmonary edema, which worsens COPD because of further impaired gas exchange, putting more strain on the heart as it tries to match oxygen requirements. If one was to cause the other, in this case, it would be most likely that COPD has caused the heart failure. COPD, as well as Patrick's smoking history, is associated with low-grade systemic inflammation and vascular endothelial dysfunction, which naturally leads to the acceleration of atherosclerosis. Atherosclerosis is understood to be part of the pathogenesis of a myocardial infarction, which leads to heart failure. The normal flow of blood through the heart and body is displayed on the screen. In left heart failure, the left ventricle is permanently damaged, thus it cannot effectively pump out a large enough volume of blood to the body. It either can't beat strongly enough, or it is irregular and rapid and does not give the ventricle enough time to refill before the next beat. Just like in traffic, if one car slows down, then all the cars behind it must slow down as well, and this causes congestion. This is exactly what happens in the heart. The oxygenated blood cannot leave the lungs at a fast enough rate, which then slows down the action of the pulmonary artery and the right ventricle. Blood keeps trying to enter from the right side, and the left side continues to be a bottleneck, and congestion gets worse. The small amount of oxygenated blood leaving the left side of the heart triggers RAS. This happens because the chemoreceptors detect a low oxygen level, which causes the brain to prioritize the essential organs of the body, and the renal artery is restricted. This increased blood volume and pressure affects the pulmonary arteries, which makes congestion even worse for the right ventricle. This is called increased preload, and over time the stress and pressure causes the right side of the heart to fail. Cardiorenal syndrome is the name of a common dual injury where heart failure has led to an acute kidney injury. A low cardiac output combined with venous congestion, inflammation, and elevated intra-abdominal pressure has led to the progressive dysfunction of the kidney. As we do not yet have direct evidence that Patrick is suffering from urinary problems, it is safest to assume that he may be in the first stage of acute kidney injury. This is known as pre-renal, which is primarily the restriction of blood flow to the juxtaglomerular apparatus, resulting in a decrease in the glomerular filtration rate. The nephron attempts to hold on to sodium and water, but by the time the filtrate has moved into the distal convoluted tubule, there is very little of both sodium and water remaining in the lumen, meaning little slips through the sodium channels brought on by aldosterone. Consequently, the capillaries in the immediate surrounding area receive less sodium, and most of the potassium stays in the blood. This results in oliguria, hyperkalemia, and hypernatremia. This is why both sodium and potassium are at high levels in Patrick's blood test. Rather than normally, the body potassium levels are 98% intracellular and 2% extracellular in the blood. So how did the potassium get out of the cells? This leads us to the possibility of undiagnosed type 2 diabetes mellitus, which explains his fasting blood glucose level of 8.5. Diabetes results in raised glucose levels, which osmotically draws water out of the cells, with the potassium passively following, causing hyperkalemia. Low calcium levels are linked to Patrick's acute kidney injury. When the kidney is damaged, the body cannot remove the phosphate from the blood at a fast enough rate, so more calcium is excreted in the urine. Calcium can also combine with phosphate in individuals with kidney dysfunction due to hyperphosphatemia, which results in hypokalemia. Having low hemoglobin levels is called anemia and is the result of Patrick's altered renal function. Healthy kidneys normally produce adequate levels of erythropoietin to stimulate the formation of red blood cells via the bone marrow. Damaged kidneys do not produce enough EPO, so this results in low hemoglobin count and therefore less ability to carry oxygen, evident by Patrick's general tiredness. High LDL, low HDL, and high triglyceride levels can be linked to lifestyle and poor diet choices and are the common marker for risk of cardiovascular disease. These blood results are also indicative of someone suffering from a condition called diabetic dyslipidemia, where the lipid profile goes in the wrong direction. This is mainly due to the lack of insulin being produced. Glucose ends up being stored as a fatty tissue. Due to the cells being starved of glucose, hydrolysis of triglycerides occurs, where glycerol and free fatty acids form and are released into the bloodstream to be used by cells to create ATP. Electrolytes play an essential role in the body, including the control of fluid levels, nerve conduction, acid-base balance, and muscle contraction. Sodium, potassium, calcium are three of the key electrolytes and significantly impair neuron signal transmission, which has a direct effect on neurological function if they are not in adequate balance in the body. As previously mentioned, chronic elevated levels of phosphate, which is called hyperphosphatemia, is believed to be a contributor to the hypokalemia seen in Patrick's results. Therefore, it is recommended that another test is conducted to measure his blood phosphate levels given his other clinical manifestations. Phosphate is normally only high due to decreased secretion of this electrolyte by the kidneys, which happens mostly in chronic but can also happen in acute kidney injury. If the glomerular filtration rate falls to below 28.8 litres per day, then the kidney's excretion cannot keep up with intake, and this contributes to hyperphosphatemia. Normally, 0.72 grams of phosphate is excreted daily. However, in kidney dysfunction, this can decrease to 0.12, with the rest remaining in the blood. In addition to this, the injured kidneys often cannot reabsorb calcium, so more is excreted, triggering the release of parathyroid hormone. This then pulls more phosphate and calcium from the bone via osteoclast. Again, phosphate is reabsorbed due to impaired excretion, and calcium is excreted because of impaired reabsorption. This condition will eventually lead to osteodystrophy, which is thin and weak bones, further worsening kidney dysfunction. Thank you for watching, and we hope you enjoyed this presentation.